Welcome back to Long Covid Doctor, an educational series for all of those of you who are still suffering from long COVID. I'm Dr. Tim Robinson, a family doctor formerly, and now for the last 5 years working in Long Covid Services. I post on all the usual podcast channels and also on YouTube. So I hope you find them helpful. And if you do, obviously click subscribe. Let's spread the word. Share any of these posts with anyone that you know who also has long COVID, or any of the forums that you may be seeing and watching. So, thanks in the meantime for all the feedback that you send in, the queries, your own comments, and I'm so sorry that I really don't have time to reply to all of those individual queries and comments. And I wish I could, but really it's just a matter of time. I'm spreading myself pretty thinly as it is, and I just haven't got the time to reply to particularly the queries I'd like to be able to do, but I just can't. I'm so sorry. But please keep those sort of comments coming in because they actually help me with my future postings and give me some guidance and steerage. So keep them coming. So there we are. Another apology, and that is my usual disclaimer. It's important though that any advice or treatment that I mention in these podcasts and YouTube videos, please should only be considered once you've talked to your own doctor about them. So there we are. So today's post is all about pins and needles in long COVID. So I hope to cover the symptoms and the conditions and then the treatments and the strategies to help you with this probably rather annoying condition of pins and needles. So here we go, pins and needles in long COVID, an update. So what are you experiencing? What are our long COVID patients telling us that they're experiencing when we assess them in our clinics? So basically, pins and needles, well, we all know what that feels like, that sort of annoying fizzing sensation that when you knock your funny bone, your elbow, and then that sends sort of nerve sort of impulses down your arm, down to your hand. And you feel a sort of a tingling sensation, a sort of a fizziness, a sort of a crawling sensation. Some people describe it, a crawling sensation like ants on my skin. There may be burning feeling, burning sensation, or even a stabbing sort of feeling. There may be numbness with those pins and needles, sort of loss of sensation, sort of a cotton wool sensation. Equally, there may be heightened sensation. So the opposite to numbness, if you like. So hypersensitivity, where everything, even the smallest of touch, elicits a sort of an uncomfortable, painful, stabbing sensation. These pins and needles can occur anywhere really, but the most common areas for pins and needles that patients are telling us are on the peripheries, on the hands, the feet, the upper arms, lower arms, but also on the legs. But they can occur anywhere really, like as I said. So on the face, for example, on the trunk, on the chest, on the back. They can occur in large areas or even just small patches. They can be symmetrical, so have a pattern about them, or they can be pretty random in where they're popping up, so no pattern whatsoever. And they can occur in the daytime only, or in the nighttime only, or both day and night. They can be continuous or they can be intermittent. So, what should you do about them? Well, basically, the message is clear. Any new symptom, you should always take that new symptom off to your GP. Say, make an appointment with your GP and present this symptom, because we've got to find an answer. We've got to find out what it is. We need to get to a diagnosis. And so the GP, he or she, will probably take you through the history. And they'll ask you, when do they start? What are they like? And what makes those symptoms, that pins and needles, worse? What makes them better? And then ask about your general health and take into account any other past medical history, any other medicines you might be taking, etc., etc. So just basically a full medical history, standard medical history. Then it's usually then on to an examination, a general physical examination, probably sort of tailored to the symptoms that you've already described, but being a sort of pins and needles sort of would lead to more of a neurological examination, examining for fine touch and pinprick sensation on the skin, just checking for the sort of the area that is affected with your pins and needles, or your numbness, your paresthesia. Then that then leads on to sort of the investigations, again guided by, tailored to the symptoms and the examination thus far. So probably just want to do the standard blood tests, looking for full blood count, liver test, kidney test, thyroid, diabetes test. That's quite relevant. We'll come on to that. So standard blood tests for long COVID, as you would do. The GP, of course, is always on the lookout for so-called red flags. Red flags are those symptoms or signs that are slightly suggestive of underlying conditions which are probably more sinister. So if you say, for example, in the general history, say, I'm feeling I'm thirsty, I'm always drinking now and peeing a lot, then the GP will be thinking, is this diabetes? Which can lead to skin problems, sensory skin problems. If you're saying that you're tired all the time for no good reason, yes, in long COVID you've got fatigue, but tiredness over and above that may be due to anemia, and in particular B12, pernicious anemia. So vitamin B12 deficiency, pernicious anemia, which again is relevant in someone who's presenting with a skin problem, neurological skin problem such as pins and needles, because B12 deficiency, one of the complications of B12 deficiency is peripheral neuropathy, so impaired nerve function of the peripheries. Then there's one-sided weakness with loss of sensation. Obviously, that's scary. That's definitely a red flag, because you're beginning to think, hello, help, is this a stroke? Maybe there's weight loss. Again, weight loss is always a scary red flag. Is there a cancer somewhere? Maybe your peripheral neuropathy, your sort of loss of sensation or your altered sensation is due to a cancer, perish the thought, pressing on a nerve, so the nerve isn't working properly. So those are the red flags that your GP will be thinking about in the whole sort of assessment. Referral on to, say, the neurologist, or investigation of one of those red flags is obviously necessary, and the GP will make that referral. So, pins and needles, like I said, and in this whole assessment, what are we trying to do? We're trying to get a diagnosis. We're trying to see whether the pins and needles is due to long COVID or something else. What could that something else be? What are what we call differential diagnoses? Well, I've already given you a few hints, a few clues. I've mentioned the word diabetes, the condition diabetes. So like I said, diabetes can cause sensory problems, pins and needles, loss of sensation on the skin. Excessive alcohol intake can lead to vitamin deficiencies, which then can present with, again, sensory impairment or changes of sensation, heightened sensation or loss of sensation, or pins and needles. I've talked about vitamin B12, haven't I? Which can occur in a condition called pernicious anemia, B12 deficiency, but also can be part of malabsorption, so gut problems. So therefore it's not absorbed from your diet. Likewise, celiac disease can be presenting with, along with bowel problems, B12 deficiency. Then there are sort of damage to nerves, so diseases of nerves, so multiple sclerosis. It's multiple sclerosis. Cardinal symptom are sensory nerve impairment because of sort of plaques being laid down in the brain on the nerves, and then that leads to sort of impaired sensory processing. So the GP will want to be looking into this and obviously sending you to a neurologist for an MRI scan to try and look for and hopefully not identify those plaques in the brain. Lyme disease, again, that damages nerves, causes nerve damage and hence sensory problems. Other diagnoses, there are a few, aren't there? There's pressure on a nerve. That could be a pressure on the nerve from a slip disc, say in sciatica, that causes sensory changes, but also carpal tunnel syndrome, where the nerve called the median nerve is pressed upon in the carpal tunnel at the wrist. Then that causes numbness and altered sensation, and as well as impaired motor function of the median nerve. So the pressure on nerves. And then finally, medicines can cause changes in sensation. So chemotherapy is a classic, but also there's an antibiotic which we use frequently for anaerobic infections, metronidazole, that can cause sensory changes. So those are the differentials that could be differential diagnoses that could be causing and explaining your pins and needles. However, if the GP has excluded all those conditions, that leaves us with pins and needles due to long COVID, which is really what this is all about. The question is, how does that come about? What are the causes for pins and needles with long COVID? Basically, it all comes down to this condition called small fibre neuropathy. I say all comes down to, no, one of the commonest causes for pins and needles in long COVID is small fibre neuropathy. That is damage of the damage or dysfunction, poorly functioning nerves. And those are the nerves that go up to the peripheries, arms and legs, and serving the skin surface. And those nerves are damaged. They are what's known as the C fibre nerves. They're if you like, the slower of the fibre of the nerves, because they're the unmyelinated nerves. Unmyelinated. So myelination, these are sort of the fatty sheath that runs along the nerve fibre. Some have myelin and some don't. The ones with myelin are very rapid firing nerves. The ones without myelin are slowly firing nerves. They're still pretty quick, but not as fast. So those are the nerves that typically can be affected, damaged or dysfunctional and result in small fibre neuropathy. How does small fibre neuropathy come about? What causes it? Well, there's no surprises here. Inflammation. Of course, long COVID is an inflammatory problem. Its effects are mostly felt because of inflammation all around the body. So any of the tissues, any cells in the body can be inflamed. And if they're inflamed, they don't work properly. So inflamed nerve cells, these in this case, those small fibers, small nerve fibers, the C fibers, they can be inflamed. And basically, evidence shows that the inflammatory cells, so macrophages, have been found in those cells, these nerve cells, plus also the cytokines, plus also the natural killer cells. These are part of the innate immune system, have been found around the cells. So macrophages inside the cells, natural killer cells and cytokines around cells are going to impair the function of those small fiber nerves. Plus also viral persistence. Okay, fragments of viral RNA, the genetic coding material within those viruses, within the SARS-CoV-2 virus and spike protein of SARS-CoV-2 virus, have been found concentrated around nerves and also within the spinal cord. Again, that leads to inflammation. And if you've got inflammation, those nerves aren't going to function properly. Then, wait for it, another form of inflammation is generated by dysfunction of the adaptive immune system. So the creation of autoantibodies, antibodies against our normal tissues, our normal cells. So we know autoantibodies are common in acute COVID and extending into long COVID. There have been in excess of 200 autoantibodies discovered in patients with long COVID. So lo and behold, of course, there are autoantibodies to nerve tissue discovered. They are going to then attack normal nerves. Then those nerves won't work properly. And then finally, in long COVID world, another common cause and a consequence of excessive inflammation is, you remember now, microthrombi, the microclots, the mini clots, which can block off the mini blood vessels. The mini blood vessels, wait for it, the mini blood vessels that serve and, if you like, take oxygen to those nerve fibers. So, there we are. Those are all the underlying causes of pins and needles that bring about the small fiber neuropathy. Then, just to complete the whole story, then there's also associated conditions in long COVID, which we're all familiar with now, and that is mast cell activation as well as dysautonomia. So mast cell activation can lead to inflammation throughout, and mast cells are concentrated and found throughout the whole system, throughout the whole body, but certainly there's plentiful supply in the connective tissues, and basically it's the connective tissues that nerves flow through. So inflammation of those nerves, those mast cells, or degranulation of those mast cells in the connective tissues will cause inflammation of the nerves. Again, another cause for pins and needles and sensory nerve impairment. What makes us suspect that mast cell activation is occurring? Well, obviously remembering the common causes, the common effects, the consequences of mast cell activation, that is gut problems, so bloating, loose stools, variable stool habit, new food intolerances, and then skin problems, hives, urticaria, cellular dermatitis, and then upper respiratory tract problems. So upper respiratory, so congestion in the sinuses, or runny nose, or postnasal drip, or sore throats. So if you've got any of those, it does obviously make you suspect that mast cell activation is present. which it's important to make that diagnosis because actually this is something we can do something about. I also mentioned dysautonomia again. We know that there's an overlap between mast cell activation and dysautonomia. We know dysautonomia is incredibly common in long COVID. So lightheadedness and faintness and palpitations and POTS, dreaded POTS, temperature dysregulation, nausea, ear ringing in the ears, tinnitus, as well as vagus nerve, the parasympathetic nerve that basically takes all the sensory impulses from around the body up to the brain. That can be working, not working properly, or overworking, being oversensitive. So either way, dysautonomia, mast cell activation, vagal underactivity, overactivity can contribute to and result in that sensory impairment and pins and needles. Basically, again, as we've found in long COVID, basically it's probably a bit of everything. Probably someone with long COVID has got a bit of all these different processes happening at the same time to varying degrees. Some more, some less. So it's complicated. So why is it important to be aware of all these sort of underlying causes of long COVID, pins and needles, all these causes that I've gone into in great detail? Well, I think it helps us because it helps us to know, it helps us with getting the diagnosis. Again, like diagnosis is key, isn't it? And we know that we can attribute these symptoms to the diagnosis, and we've actually gone through that process of ruling out more serious underlying causes, and as a consequence, that helps us with how we're going to manage the presenting symptom, in this case, pins and needles. That obviously is also quite good because it gives us peace of mind, and that understanding gives us peace of mind and helps us the validation thing of, we can be believed, and helps us accept it for what it is. And acceptance is so key because that brings, it brings great peace of mind. So that leads us on to the big question, and that is, this is the one you're really waiting to ask, and that is, how are we going to treat it? How are we going to manage this annoying symptom of pins and needles? What can we do? Well, what can I say? Basically, there is no specific treatment aimed at restoring nerves, because basically the underlying problem with pins and needles is because we've got the nerves serving that area that are feeling pins and needly. It's not working. The nerves are not working properly. Unfortunately, there is no specific treatment that addresses and puts out that nerve, that cures it. Okay, it's really just symptomatic treatments. Yes, we have treatments that will dampen down the activity of those nerves, but not mend those nerves. So basically, we have treatments that are aimed at, if you like I use the word dampening down those overexcitable nerves. Okay, so there are a few medications that you can be prescribed by your GP that dampens down that overexcitable nerve. And the first group of drugs, there are a couple of groups of drugs, or three to be precise. The first is the gabapentinoids. Okay, so the two common ones are gabapentin and pregabalin. These reduce nerve excitability, and they also are very good for neuropathic pain. Remember, I talked about that burning pain that a lot of patients are experiencing, the stabbing pain. That's neuropathic pain because it's all to do with the nerves. Okay, nerve pain. Whilst we're on neuropathic pain, the first line drug that we in general practice world always start with are drugs that are in the class of tricyclic antidepressants, amitriptyline. Okay, I've used the word antidepressant. Well, I'm saying that because, yes, amitriptyline was the original antidepressant. It was brought out like 50, 60 years ago, but none of us use it for depression now. We've got much nicer, cleaner, more effective antidepressants. So when you look, if your GP prescribes amitriptyline, and you look on the label, on the box, and it says this is an antidepressant, don't get the wrong end of the stick. It's not because your GP thinks you're depressed. No, it's a drug that we use. It just happens to be an antidepressant. It's a drug that we use that is really excellent at neuropathic pain. So typically we start with 10 milligrams at night. Why? Why at night? Because it can cause sedation. So by the morning, it's worn off. So you don't have that hangover effect. If you took it in the morning, you'd be feeling drugged up and sort of drowsy. Yeah, drowsy during the day. So amitriptyline is an excellent drug. You can wind it up to 50 milligrams, but actually by 50 milligrams, even if you take it at night, you feel probably a bit drugged in the morning. So 10 to 20 milligrams is the usual dose for that. And then the final group of drugs which we use for modulating pain, it's a sort of, pain modulation and help with pain processing, correcting incorrect pain pathways, is something called an SNRI, so selective norepinephrine reuptake inhibitor. So the one that is most used and has a license for this is called duloxetine. Again, your GP will be able to prescribe this. Again, it's effective. So those are the pills that help us dampen down those overexcited nerves that are causing you to have your pins and needles. There are also some topical applications that actually help a little bit. So lidocaine gel can help. So it's a gel which you can apply to the area that's annoying you with their pins and needles. And then capsicum patches, again, basically it's derived from a herb, not a herb, a condiment, I don't know, a seasoning called capsicum. So that can be applied, and we use this in post-herpetic neuralgia. And then finally, supplements. Okay, you may be deficient in vitamin B, in the vitamin Bs, particularly vitamin B1 and vitamin B12. So I mentioned vitamin B12 earlier with pernicious anemia, but if your vitamin B12 is slightly borderline, you can actually supplement it as a tablet. It's not as bioavailable as, or not as effective, and it's not the treatment for B12 deficiency, but it's better than nothing. So those are those we sort of can treat this pins and needles, long COVID pins and needles. So what can we expect? Basically, when I talked about the causes, basically the majority of the causes is due to inflammation of those small fibers, the small nerve fibers, the C fibers, small fiber neuropathy. So inflammation. So basically, inflammation does settle with time, and the autoantibodies again along with the settling of inflammation, basically autoantibodies will clear with time as that inflammation subsides. Nerves that have been damaged or even killed, if you like, will regrow. Nerves regrow. Peripheral nerves regrow We've known that for many, many decades. We know that they regrow and sprout little nerve endings and reconnect and come alive again. We also know that actually incidentally happens in the brain also. This has only been known for the last 10, 20 years. Neuroplasticity, rewiring, refiring, rewiring neuroplasticity. So damaged nerves that are not working properly will, and then hence bringing about your pins and needles, will repair themselves with time, but it takes time. Remember I said one of the underlying causes could be that the nerve has been starved of oxygen because of a microthrombus, mini blood clot. Well, the body is clever, and there is a process called angiogenesis, angio blood vessel creation, neoangiogenesis, and that creates pathways, bypasses any blood clots, but also blood vessels clear clots eventually. There's the process of what we call recanalization. So sooner or later those blood clots will be cleared, and then if they're clear, then the blood vessel becomes patent again, and then blood goes through it, and then that serves the tissues that have been up to that point starved of oxygen. Remember the other causes: mast cell activation, dysautonomia. Basically, mast cell activation, we know, again, listen to the podcast on mast cell activation. I recently posted an update on that as well. H1 and H2 blockers reverse that. And, if you've got all those other, like I covered very briefly, the gut problems, the skin problems, the upper respiratory problems, then those H1, H2 blockers will address those problems also. Dysautonomia, again, hopefully will settle with time. Again, but back to the original question that I asked, and that was what to expect. What are our findings, and what have our patients been telling us? Basically, most people with peripheral neuropathy or pins and needles, these problems with small fibre neuropathy, clear over a matter of months, or months as a range, basically months up to 1 to 2 years, because of all these processes that are happening down the infection, the sort of clearance of the blood clots, the mast cell activation, etc. It just takes time. So, is there anything else we should be doing? Well, yes. I mean, we mustn't forget. We mustn't treat these pins and needles or neurological problems in isolation. We've got to put it into the whole picture, the bigger picture of long COVID. So we must be addressing all those other elements of long COVID, the fatigue, obviously using the 3 Ps, the planning, the prioritizing, and the pacing, just to manage the fatigue properly. Some gentle reconditioning of those muscles, so maybe some stretching of the ligaments, the tendons, the muscles, with some gentle yoga, and sort of trying to attack and dampen down stress and worries, etc., with, say, maybe some focused sort of mindfulness or focused breathing strategies. And then sleep hygiene, really important. Sleep is the big restorer, isn't it? So think about sleep hygiene, sort of blackout curtains or eye visors, maybe some earplugs if you've got noisy neighbours. We've got to be looking after our sleep, getting some quality sleep. And then, of course, my favourite is diet. Make sure you eat a mixed, balanced diet to give you all those factors, components that will go towards helping you rebuild those cells that have been damaged, and also providing you with, the fruit and veg, provide you with all those natural anti-inflammatories, the vitamin C, of course, but also those polyphenols, those naturally occurring anti-inflammatories that dampen down inflammation, the antioxidants. And then finally, a mixed balanced diet will give you the prebiotic fibre, which will nourish your gut microbiota, which is so important for supporting your immune system, for vitamin production, for neurotransmitter production, for a good brain-gut balance axis, so many other functions. So there we are. That is my update on pins and needles in long COVID. I hope you found it helpful. And like I said at the start, this is an educational series for those of you who still have long COVID, and in particular, this is all about the pins and needles that a lot of you have been, are maybe still experiencing. Remember my disclaimer with what I've said. Basically, any advice or treatments that I've mentioned, discuss with your doctor. So always remember, safety first. So there it is. Like I said, I hope that's really helpful for you. So click subscribe if you're looking at this on YouTube. Spread the word, share it, because I want as many of you long COVID sufferers to benefit from these educational sessions that I'm putting out there. So it improves your understanding of the condition, the causes, understanding of how to manage it in the best possible way. So there we are. That's it. So in the meantime, I wish you all well, and all well with your long COVID recovery. So all the very best to you, and cheerio. Bye.